On that slide where for the future model for primary care, you had 4 MDs, I think, right? And each had 2 MAs and 1 APRN, I think. What would be the plan for smaller clinics that may have like an equivalent of 2 MDs?
Hello? Yeah, that's a great question. So that was sort of a, it's kind of a guideline, but we are dealing with sort of infrastructure issues too, and bricks and mortar. So we're not going to be able to supply that whole team-based care model, and the team members aren't going to necessarily be in that clinic facility. So for like your example with Chris Jose is that clinic may share some of those other team-based resources with the FIC docs or King Street docs. So the idea is to hopefully have the team-based or the central support, supporting about that 3 to 4, maybe even more primary docs, but not necessarily in that clinic, but more remotely if that works okay. So it's going to be a play around. We're definitely going to have to see what works, what doesn't work, what we need to have on site, what we need to make room for on site, and what we need to then think about more centralized just from a space standpoint.
I'm sorry, one more question for the, I think, SSP? Yeah. For one of the measurements, sorry, I can't remember which one, SSP, I think, you said that everyone needed to reach greater than 75%. Is that for the overall average, or each individual hospital needs to get over 75%?
I can answer that. So, yes. It's both. The whole system needs to be above 75%, and then each hospital needs to be above 75%. Because every one of us have declared which hospital we're affiliated with, and so it's in our interest to support that hospital's success, because if it doesn't make it, then we lose out if we are affiliated with that hospital and they don't hit 75%.
We should provide a little context to that. I mean, this was, it's not just about the numbers. It was really under the premise of the way we created the premise of this when we went back 3 years ago, and that was trying to differentiate it from the managed care days where it was an economic model. And this is really about it being a quality-based model. And so in order for one to really get into the money, if you will, it's got to be based on quality, and it's got to be based on outcomes, performance. And so it really is intended to drive quality-based performance over and above economic-based decisions. And so that's why we have those platforms of quality performance that allow us to qualify for payments.
Dr. Nakamoto.
Thank you for all the work you folks have put in. My question is, as HHP grows to incorporate specialists, a lot of the support that you folks have is based on Epic, as far as best practice alerts, e-consults, effective communication. My question is, what happens if a community specialist is not on Epic? I'm just asking.
It's a good question. Would anyone want to take a first run at that?
I'll try to tackle that a little bit, because I agree. It's the Epic, I think, our EHR, that is going to give us a lot more interconnectivity, a lot more of that coordination. And so, of course, we would like to support, specialists that have, to try to move towards that seamlessness, or maybe even interaction between, or interface between the Epic and their specific EHR. But it's going to be a little bit more difficult, absolutely. We're going to have to go a little bit more old school, but I think that the collaboration can still be there. The phone calls, we could always pick up the phone, and kind of talk with our specialists that way. So I think there's workarounds to that. I wouldn't want anyone to not think of joining HPH and becoming our member just based on their electronic medical record, because I think we could support them both ways. It'll be harder, but we could definitely support them that way.
Yeah, I guess the first thing that comes to mind, and Jared can talk a little bit about, how we can support folks who aren't on Epic. But remember, this isn't about process. And so the processes are intended to enable ease of practice and ease of making the right decisions and ease in supporting quality care. But it's really about outcomes, right? And so as long as we can push the information out in some form or fashion, as long as we can provide tools, while it's easier if someone's on Epic, it's not the only way to get it out to them. Certainly what we're looking for are providers who are performing from an outcome standpoint. It's not whether or not they did this, this, or this to get to that outcome. It's did they provide the outcome on behalf of the patient. That's really what this is about. It's not, these aren't process exercises, although we believe that oftentimes it's those processes that will get you to those outcomes. So how do we push those tools out? I hope that makes some sense.
Yeah, I think that's right. I was encouraging you to know who's in the network. Well, that has to have a reason, right? There has to be a value. And the value is that you have a level of interaction and collaboration with them that makes you more efficient and effective. And to be honest, with the programs that are coming, like CMS's, they are complex. The CPC Plus thing is pushing a level of complexity that is going to be kind of challenging to address without being on one EHR. Doesn't mean we wouldn't do it. We absolutely would work, but we just need to understand that that's a challenge. It's a significant challenge. Maybe one more question, because we're actually a little bit over 8 o'clock. So anyone want to send us home with a zinger? Looks like you guys are ready to go home and face the traffic then. All right, we'll stick around and answer questions for those of you. I wanted to thank you for your time and attention tonight, for your devotion to medicine and all of our patients, for your partnership in defining a new model of care. Let's go build a healthier Hawaii and be the leaders in healthcare transformation. Good night.
Thank you all.
I was born